Thank you, Dr. Gupta. Good morning to all of you. I'll just talk about how to optimize the outcomes of your benign eyelid lesions. Simple surgical techniques. We have videos for some of them. I hope you enjoy the show. So, what we do for lid margin lesions, you have different kinds of marginal nevus. They may be deeply pigmented or even lightly pigmented. What we do is a shave biopsy. And if you see the video, we're using a 15 number Bart Parker blade to gently cut right across the base. The purpose of this excision is not a complete excision, it's a shave biopsy. So there will be residual tumor. The purpose is to give a better cosmetic result. If you note carefully, you'll see there is some residual tumor here, but that is on the posterior lamella. And a gentle cautery to the surface, and we are done. Small cystic lesions, we often see these lesions around the lids. And there are various ways of doing it. You can either use cold steel or you can use a monopolar radiofrequency probe to excise the lesion. We usually leave these to granulate and the wounds heal within a week's time. So what I'm doing is I'm cutting a collar around the lesion itself and then placing traction on the tumor. I would gently separate it from the orbicularis muscles. You can see the interference pattern on the screen because of the radiofrequency. So just place traction on the lesion and you can cut out the orbicularis fibers individually and release the entire lesion. So the one that I'm excising here is a keratinous cyst. There's another lesion on the upper right side, multiple transparent lesions that you see. Those are eccrine hydrocystomas. And in one sitting, we did both the lids of that patient. And this raw wound that you have, we don't do anything. We just patch it up, remove the dressing the next day. Patient can have a head bath from the following day onwards. And these heal very well without any scarring. And the third lesion that you see here, this translucent bluish lesion, that's an apocrine hydrocystoma. Other superficial lesions where you can use the shave biopsy or the excision techniques that I showed you here. What is this lesion? With a cerebriform pattern. I identify people on the third row who are expected to, yeah. Okay, these two lesions are the same histologically. Alright, this is cerebriform and this one has these pits on the surface. They're both seborrheic keratosis. Alright, this is a classic cutaneous horn and that was a viral wart. Okay, a large cystic lesion. Here what you would do, you would remove an ellipse of skin as well because you have excessive skin here thanks to the stretching. And this is a tarsal cyst. So here, unlike the previous surgery where I showed you the technique using the radio frequency, here we'll use cold steel instead. But you could do either. Now these cysts have an attachment to the tarsal surface. And you cannot excise the cyst without violating the cyst wall. So there will be a small remnant of epithelial left on the tarsal surface, which you can either treat by cryotherapy or with alcohol, absolute alcohol, or sometimes I even marsupialize that little portion. So that's the firm attachment to the tarsal plate that we're excising in the end, and it is going to get breached. So you can see the sebaceous material coming out now. And the evil deed is done. And in this particular case, we applied cryotherapy. So the purpose of excising that excess skin is to give a better cosmetic result. You could always titrate that. This is a classic infiltrative lesion, the plexiform neurofibroma. You cannot excise the tumor in toto. So in these situations, what we do is eyelid debulking, and my colleagues we had worked on this technique which we call the template technique, where we do a one-stage debulking, including the horizontal as well as the vertical components, and reduce this large bulky lid into a smaller, ptotic, manageable eyelid. And this is how we were doing this. So you design a template on the opposite lid, place it on the medial side, because what you're going to basically do is convert this large bulky lid into a flap which is based on the medial side, from where it is going to draw its vascular supply, and excise everything beyond that. And then reform the lateral canthal tendon and put it back in place. So this is how we used to transfer it, flip it across, transfer it, make your drawings, and then go ahead and do the excision. And this is what you get. You get a ptotic lid, but it's debulked and cosmetically more acceptable to the patients, because they often suffer from social ostracization as well. This is when you can go in and do a tarsofrontal sling for these patients. To cut it short, what we were basically trying to show you is how to use the appropriate technique depending on the nature, size, and the location of these benign tumors. Thank you very much.